Here we are, back at it again. You ready?
We're ready.
Shut the fuck up. What? Okay.
I don't know if anyone can hear you online.
Can you hear me? Can you hear me? Please? All right, great. So no one online is actually listening. Do you know how scary it is when you hear your name in the online class and you're like barely paying attention, you're half asleep? Hey, Frederico! Pay attention to me, God damn it!
Oh, Federico says yes. He just said yes. And Connor Thompson can hear it, so.
Gonna fuck you up. You're sitting there, and all of a sudden Arnie Hill's like, "Hey, Adora." You're like, "What the fuck?" Yeah, I hate that shit. Online class is bullshit. We're not recording these anymore. All right. What? Am I wrong? No. Yeah. All right. Let's get started with a little housekeeping.
You need to share the slides on.
Why? So I just go like this. Oh, okay. I remember this. I remember this. Hold on. You go like this. Then you go to.
Sharing slides versus screen recording is different.
Yes. Yeah. Oh, I need to share my screen. Yeah. Okay. Share. I don't want to update my driver. Not now. This one. Yes. Okay. All right. I thought you said you were ready. Everybody, shut up. Okay, it's the last week. It's week 7. You got to be tired of this shit by now. You're like, oh, thank God, they're going to be done. I can finally go home after school and go to bed. That's good. Me too. Excited. All right, so it's time for a little housekeeping. We pulled a little trick. We only told people that the internal competition was happening in the lectures. It was a way to see who was watching the lectures. You're all here, so you probably figured it out. Good job. Tomorrow is Tuesday. On Tuesday, there will be this. In 26 York Street, we'll be having a little review where people can come and get caught up on shit that they may not have been paying attention to, or maybe they missed the week, or maybe they're just not super comfortable with it. I've been bitching for the last 3 weeks about how I don't have time to teach you how to use a BVM in the sessions, which is true, but I will have time to teach you how to use a BVM tomorrow. So if you forgot how to do that, which you shouldn't have, but if you did, you can come to this in York Street. We'll help you out, okay? Do we have a sign up on SLHQ for it? Okay, so yeah, just fucking show up, all right? There's no rules. If there's 3 million of you there, we'll probably make some of you go away or something. But just show up and we'll figure it out, all right? So that's that, 6 to 8. Odds are we'll probably be there a little extra if people need more time. And that's for you, so please don't waste our time. Great. Okay. Internal competition is coming up. You should have your teams by now. Did anybody not get an email with their teams for the internal competition in it? That was supposed to. If you're not doing the internal competition, then this does not apply to you. Everybody got it? Have you made contact with your team? Does your team seem like cool people, or do you hate them? The worst. Fuck them. All right, great. That's good. You got to learn how to deal with people we don't like. I don't like anybody. There we are. All right, so it's coming up. There also is the grading sheet. So if you guys have hopefully gotten a chance to look at the grading sheet, if you haven't, I just want to call out a couple things that are super important. The main one is you've seen it by now. You know how much communication counts. It's a huge chunk of the score. This is true for real in SimWars, the actual real competition nationally as well. So that's kind of guidance there as to what you should be focusing on when you're practicing with your team. The other thing that I want to call attention to is the fact that your year is written on these sheets for all the tutors. It's not so much weighting, but we will be taking into consideration stuff that you may or may not know based on your year and trying to even stuff out that way. If you perform the shit that we've talked about for the last 7 weeks, you're going to crush it, right? You don't have to bring in any exterior knowledge. You don't have to bring in any of the stuff they teach you at RCSI. If you do bring that in and that makes you look good and you're an SC2, that's probably not going to give you as many points as it maybe would if you were a Gem 1, right? Or a Med 1 or one of our foundation years that has the balls to step up and do this, which is awesome. So just bear that in mind. It's going to be a little bit like, you might be thinking like, oh, my team's all SC2, my team's all, SC1 or people with a bunch of experience, whatever. We are accounting for that. And the accounting for that has worked really, really well in past years to the point where we've like made teams out of entirely Gem 1s basically, or entirely Med 2s or whatever. Like, so don't freak out. What's up?
Also, probably none of your teams will be just 1 year because we've made them so they are mixed.
Yeah.
On purpose.
You're not going to have just 1 year. But don't be looking at your team and be like, oh my God, there's an SC2 in here, I'm going to look like an idiot. Because that's not going to happen. Because SC2s are dumb. Trust me. I know, I spend a lot of time with them. So don't worry about it. All right, last thing, we've pushed this bunch. I'm going to keep pushing it hard. Tell your friends, tell everybody, we need volunteer patience. If you're in that group chat already, you saw Adara yesterday posted one of the paid opportunities that's coming up. There's cash money in it for you. If you put in your name into the form and are not yet in that group chat, don't worry, I'm going to sort through that tomorrow. But these opportunities will continue coming out. I don't know how much that one's worth. It's like $50 or something, right? Yeah, so like that's 50 free bucks for just letting people touch you. I mean, that's, legality debatable. But yeah, there's some ones that are worth 100 that come up too. So like, if you're looking for some extra cash and you don't want to sell your plasma, there you go. Get the money. Secondary survey is what we're talking about here tonight. This is a bit of an interesting lecture, given that we start to, at this point, talk about RCSI doctoring stuff. And I hate that. So, we're going to try to keep it light. We're going to try to keep it easy. Our goal here is to give you guys a reference for some of the stuff that you maybe want to do based on specific chief complaints, right? I skipped one. There's the disclaimer. I'm not your dad. I say stuff, people hate it, but it's not RCSI's fault. All right. Here's what we're going to do today. What we're going to do is we're going to break down a lot of our kind of more iffy assessments that we get taught at RCSI into some really discrete chunks based on systems, right? So you get taught like a cardiovascular exam, right? You get taught like a respiratory exam. And all that stuff's actually really, really good stuff to know, and you should know it. But I want it to be simpler than that. Like, I don't give a shit if you're checking for like flapping asterixis in an emergency patient doing a respiratory exam, right? Or I don't care if you're like delicately feeling all the fingernails for clubbing in a patient that maybe has some sort of cardiovascular problem, right? I want to take away all the bullshit, leave you with the stuff that's going to discover whether or not the patient's actively about to die on you and send you forward from there, right? So we're going to try to make it a little bit simpler, and we're going to break it up into some systems that you may not have heard of or may not have been told like there's an exam for, okay? We are going to talk about detailed trauma assessment. We're going to talk about that pretty briefly. I know I promised a couple of you that there was a video. I can't find the video we made at Pitt anymore. It was like 10 years ago. I think it may just have gotten taken off of YouTube at some point. We'll create one tomorrow, probably. I'm so tired. We'll create one tomorrow and put it up there about a good solid rapid trauma exam. But we'll talk a little bit more about that. We want to recall some common DCAP BTLS findings. DCAP BTLS is something that's been a bit iffy for you guys. And then really this last learning outcome is actually the whole point of SimWars, right? That one at the bottom, if you can do that, you've gotten the rest of what we've tried to teach you this year. So that's kind of the culmination of what we're learning, which is figuring out how we actually run the first 10 minutes of an emergency case, right? So if you can get that one, if you're like, man, I'm comfortable with that learning outcome, you win. Congratulations. Hell yeah. That's great. You guys hate that shit, don't you? What is sample? Signs and symptoms? Allergies. Medications. Past medical history. Last oral intake. Events leading up to what happened, right? There we go. What's OPQRST? Fuck yeah, it's Socrates. Great, good job. All right, awesome. OPQRST is dummy Socrates. Onset, provocation, palliation, quality, radiation, severity, time. A way to assess pain, and pain specifically. All right? Sample is our classic way of getting a basic history in an emergency patient. We've talked about this shit at length. This is some of the most important parts of your secondary survey. If we don't get this information somewhere else, this is where we end up taking the time to interview the patient. So once we've gone through our ABCDEs, once we've corrected our life threats, got our initial set of diagnostic stuff off, we get to a point where we're lull, bless you, and then we start to talk to the patient and do a little bit more of a detailed exam on the patient. All right, here's some systems. Where did I get these systems? Because it sure as hell isn't our CSI. Because some of those I know you've never been told about before. Or at least you haven't been told, like, there's an exam for this specific system. So these are the 8 systems that the National Registry of EMTs in the States breaks up medical assessment into. And remember, we've talked on and off a little bit about how the fact that we break up medical versus trauma assessment when we assess paramedics, and that's a bad idea because people can have more than one thing wrong with them at a time. But this is what that is. This comes from our medical assessment skill sheet. So we talk about respiratory, cardiovascular, neurological, musculoskeletal, integumentary, anyone? Skin, nice. Psych-soc, gastrointestinal, and genitourinary. And sometimes you see GI/GU mixed together because honestly, like, you do them both more often than not, right? So the way I want you guys to approach this, and this is what I tell paramedic students as well, is I want you to approach this from a very simple perspective. And that perspective is try to pick 3 that maybe you think is wrong with the patient, right? And why do I say that? Anybody know? Because you could be wrong, right? We all know what confirmation bias is, right? So that's when we think we know something, we think we know the way things are going to go, and we look for things to support that diagnosis or that decision, right? So if I see this patient sitting in front of me with crushing chest pain, and I say, oh, that's probably an MI, I'm going to do a cardiovascular assessment full stop. Maybe I'm missing something respiratory. Maybe I'm missing something musculoskeletal. Maybe I'm missing something psychological, right? So we really want to make sure that we get this down. So I want you to pick at least 3 when you can. And be cognizant of the fact that this may be time limited and it may be multiple things happening at once, right? What is in our respiratory exam? Someone that is done a respiratory OSCE. Please tell me what's in a respiratory exam. You don't remember? Fuck the hands! All right, I like that. That's good because that's E. That's our E, right? Exposure is super important. So respiratory, what are we exposing? Chest, right? Arms, chest at least, so pants up. We want to be exposed, all right? Great. What else is in a respiratory exam?
Airway breathing.
Okay, airway breathing, awesome. Lung sounds, very good. So auscultation, right? What do we teach you guys?
Chest voice.
Inspect, then, come on. Palpate, yeah, then percuss, auscultate, right? Okay, so let's break this down into a few things. So we got a respiratory patient. This is not an exhaustive list of some of the stuff that we think you might want to do if you have a patient that you're working up for respiratory complaints. And I see you going nuts with that percussion over there, my guy. And realistically, do we percuss patients all the time in the emergency department? Probably not, right? Do we percuss patients if we're suspicious that there's something going on? 100%, right? If we're maybe thinking about what is this? What is this, a pneumothorax versus a hemothorax? Percussion can be very valuable, right? So we're going to inspect the airway. We're going to do inspect, palpate, auscultate, percuss. Inspect the airway, inspect the chest, moving on to palpating the chest, right? I don't care about this, like, measure chest expansion bullshit, right? I care about palpate the chest. Do we have equal chest rise and fall, right? Auscultate. We always are missing auscultate. And I want to auscultate in the breathing assessment, like as part of our ABCs, but we're also talking about auscultate in this context. Percuss? Maybe. Does everybody know how to percuss? It's okay if you don't.
What's percussing?
What's percussing? Hitting shit. Seeing if it makes a sound. Percussion, like drums, right? So when we percuss, what we're doing is we're creating a sound wave and using how that sound wave interacts with the body to try to figure out what's going on. Yeah? Auscultate means listen with the ears. So that's our stethoscope, right? So we use our ears to listen to the patient. I know these words are crazy, right? Why don't we just say listen? Why don't we just say tap, right? So inspect, look, palpate, feel, auscultate, listen to, percuss, hit, right? So when we percuss, you'll learn this at some point at RCSI. I really don't care that you know it all that well, but we're trying to instill a sound wave into that patient so we can hear what's going on. So for example, let's talk about lungs. What's in lungs? Air, right? So if I percuss air, what do you think the sound that air makes is going to sound like? It's going to sound kind of hollow, right? It's going to sound like the sound is reverberating around because it's bouncing around in that air cavity. So we call that resonant, right? That is a resonant sound. So when we tap and we hear that echo of that sound bouncing around in the air, that's resonant. If we have too much air, like we're in a tension pneumothorax, we'll think about hyperresonant, which is like too loud. What about if we tap liquid? It's going to be dull, right? It's not going to make as good of a sound because it's filled with goo, right? That's simple. So that's percussion. And that can help us, in this context, differentiate between a pneumothorax and a hemothorax, right? Either air or blood in the chest cavity, because they're going to make different sounds. Air is going to be resonant. Blood's going to be dull. It can also help us differentiate between, like, if there's consolidation in the lung, so an area where the lung is kind of condensed down on itself, we can look there too, right? We care about respiratory rate, and then we care about some more numeric stuff like SpO2, so pulse oximetry, right? Notice how that's after all the shit we do with our eyes and our hands. We care about EtCO2. What's EtCO2, anyone? End-tidal capnography. What does that tell us?
How much the air is getting to the cells and back.
Yeah, so it tells us how much carbon dioxide we're exhaling, right? In a measure of millimeters of mercury of carbon dioxide or kilopascals of carbon dioxide, right? It tells us what partial pressure of carbon dioxide is coming back out of our lungs, which can tell us a few things. It can tell us how well oxygen is getting to the cells, right? It can tell how well our lungs are perfused. And the nice thing about end-tidal CO2 is it's a much more reliable way of counting a respiratory rate on the monitor, and it is also a much more up-to-the-second indication of the patient's respiratory status than pulse ox, right? You'll see a CO2 start to dip or climb before you'll see an oxygen saturation change in the blood a lot of the time, because it's measuring every expiration, right? It's not measuring just the general oxygenatedness of the blood. It's measuring every respiration. You know, I've been yelling at you guys for the past few weeks about reading the rest rate on the cardiac monitor and how that's useless, right? It is useless when the monitor is getting that number from the ECG leads, because that is a worthless way to try to determine rest rate. It is slightly more better if it's getting it from an EtCO2. Still not as good as counting it your damn self, but still better, right? pH. What's pH going to tell us? In the context of respiratory. Some people are looking at me like I'm crazy. Who knows about how to read an ABG or a VBG? It's okay if you don't. All right, so here's what I'm going to tell you. Carbon dioxide is acid. Cool? So if you're not breathing enough, you get too much carbon dioxide, that's an acid. So your pH does what? It's down. Great. Carbon dioxide is acid. That's way simplifying, but whatever. All right, so we get the pH from an ABG or a VBG, so an arterial or a venous blood gas. I really want you guys to start calling for these bloods as we get into the start of the scenario. So when we say, let's get that IV line, that's when we start saying, all right, we're going to get an IV, we're going to get a VBG, we're going to get what other bloods we think we need, right? Chest X-ray is another great one for imaging. Right? Anything else you guys can think of that you want to maybe toss on this bad boy? Ultrasound of the lungs? You could EFAST, you could do the E part of the EFAST, right? So if you're thinking maybe they do have a pneumothorax or maybe they have a hemothorax, you can absolutely do a little EFAST action there for sure. What else? Anything? It's okay if the answer is no. If you think I did a good job and there's nothing else you want to put up there. No pressure. So tracheal deviation. So tracheal deviation comes up a lot in our CSI exams because they're talking about it in the context of like an apical malignancy. In our emergency scenarios, tracheal deviation is often interpreted as a sign of a tension pneumothorax, right? In the real world, if a patient has tracheal deviation from a tension pneumothorax, they are going to be dead in the next 30 seconds. If you get that bad, that you have so much midline shift that you, with your own little eyes, can see the trachea not being where it's supposed to be, that patient is going to crash imminently, right? So I don't like tracheal deviation as a way to diagnose tension pneumo. I think it's way too late a sign. We should figure that out earlier by listening to lung sounds, right? By looking at the chest rise. Now, absolutely in the context of like a malignancy that's pulling that trachea to one side or another, definitely something to think about. What else? So breath sounds, we've got auscultate the chest. Good stuff. Anything else? So respiratory effort, exactly. So we want to just, when we look at respiratory rate, that's not good enough, right? We talk about respiratory effort. We talk about how much we're breathing, but how deep and how labored and how much effort we're putting in. And is it regular or irregular, right? That's a great one. So respiratory rate and effort. Anything else? It's okay if it's no, we can move on. That's a pretty good list from my perspective. If you guys get through all that with a respiratory patient and know each of these results, that would make me very happy, okay? What about cardiovascular? What's in our cardiovascular assessment? I intentionally didn't advance the slide. Sorry? So pulse, right? Rate, character, quality, rate, rhythm, great. What else? Blood pressure, awesome. Good vital signs. Yep. Cap refill. Auscultation. Inspect, palpate, auscultate, percuss. Right? Yeah, definitely. I'd throw skin kind of in everywhere. I think skin's always important. That's why it's in our ABCs. Because, you can see skin signs in respiratory disease too, right? So inspect, palpate, auscultate lungs. We can look for edema in the feet and the sacrum, right? We think about blood pressure. We think about heart rate. And I really, really want to divorce heart rate from pulse because we've seen a lot of people over the last few weeks be in the circulation assessment, be like, okay, I'm assessing circulation. The heart rate on the monitor is 75. That means we're fine. Lies. Damn lies. We always feel the pulse. So we might have a good heart rate on the monitor, but it might be fucking worthless in the patient, right? Maybe we don't have enough blood to circulate and the heart's squeezing away, but there's nothing for it to squeeze on, right? Maybe we have some sort of weird conduction that looks okay, but is not perfusing. Oh.
Or you actually have a hole in your septal defect.
What the heck? Why is Savannah talking?
Also in the middle.
We'll mute that. I don't know where that came from. All right. So, blood pressure, heart rate, SpO2 again. There's some overlap, right? SpO2 can be an indicator of our respiratory status or our cardiac status. Cap refill, good one. Where do we check cap refill? Yeah, fingers. I was waiting for somebody who's on pediatrics to be like mid-sternal, right? No, fingers is fine. ECG, 12-lead ECG. Did a lot of 12-lead ECGs this week. Lots of people looked at it and said something completely wrong when they saw it, but at least we got that ECG, right? That's great. I'm going to teach you how to read ECGs next semester. For now, if you get that ECG, you're like, that looks kind of weird. I'm going to send it to a cardiologist, have him look at it. It's good enough for me, okay? Maybe a right-sided 12-lead ECG. What is that? Well, it's a 12-lead ECG, but on the right. So, when we look at a 12-lead ECG, we'll talk about this when we get to our ECG classes next semester, but we're taking a picture, an electrical picture of the heart, and we're normally doing a left-sided 12-lead, right? So that's V1, V2, V3, V4, V5, V6, which gets us a good picture of most of the center and the left side of the heart. It doesn't give us a great idea of right heart function. So right atrium, right ventricle don't get seen super well on a normal 12-lead. So what we can do is we can take all those leads and flip them to the other side. And that gives us a better picture of the right side of the heart, right? Anybody know when you would be concerned that there was a right heart dysfunction, that you needed to get a right-sided MI? I don't expect you to know this. Spitball for me. So yeah, so maybe if you're starting to think about like cor pulmonale, where you're absolutely backing everything up for sure, that's a little bit late, but it's something to consider. So what are symptoms of like a right-sided MI in a patient? So it could be. I'm thinking more of like if we had a heart attack, an MI that's affecting the right side of the heart. So are we going to lose for our systemic circulation, do you think we're going to lose preload or afterload? We're going to use preload, right? We're not getting enough blood back into the left side of the heart. So our right-sided MIs tend to be our hypotensive MIs. They tend to be our volume-dependent MIs, right? Where we drop our blood pressure because we have that drop in preload. We may also see fluid back up to the extremities as opposed to fluid back up to the lungs. That's all. And again, a little bit outside of what we're talking about tonight. FBC, what's an FBC? Full blood count. Why do you think we want that for cardiovascular? Could be. So blood loss may not show up in a full blood count if it's really, really recent, right? If you have a trauma patient that comes in and is bleeding out all their bloods, and you take a full blood count, what a full blood count is doing is counting the parts percentage of the thing in the blood. So you may have normal results for a little while because they're bleeding out all of their bloods at the same time, all the different parts, so it might be normal, right? Might be deranged, you don't know. It's much better for chronic blood loss, right? If we have a chronic loss of blood where maybe we're keeping our volume okay, but we're depleting our hemoglobin, that's a great time for a full blood count. What else does it tell us? Why is that useful? Thinks about infection, right? High white cell count, thinking about infection. What else? Yeah, platelets to tell you a little bit about your coagulation status. Are we burning through platelets? Are we making enough platelets? Could be. Electrolytes aren't going to come on a full blood count normally. We'll get there though. You're right, but we'll get there. So that would be another thing that we might want to look at in a cardiovascular assessment is we might want to consider electrolytes. Because some of our cardiac dysrhythmias can be caused by electrolyte derangements, right? So we might consider a blood test called a urine and electrolytes, or U&E, right? What about cardiac enzymes? Anybody here ever heard of any cardiac enzymes? Oh, that's the one that everyone loves. That's the one that we use diagnostically, right? Anybody ever heard of any other ones? All right. Anything else? It's good enough for me, man. All right, so there's a few other ones, and depending on what hospital you're at, you can get a cardiac enzyme panel that will get you a number of them, but it's always going to get you a troponin, right? So that's going to tell us if we have myocardial ischemia, which is really, really important. So we want to get that too. Chest x-ray, and then an echocardiogram. If you guys can figure out how to read an echocardiogram, like fucking good for you. All right, so that's just some basic stuff, right? What's up?
So in the scenario, do you just ask for cardiac enzymes?
So what you'll do is you'll say, I want to get a cardiac panel, I want to get cardiac enzymes. You can even ask for troponin, whatever you want to do, right? We try to not region lock SimWars until we start training for semester 2 when we're training our individual teams. Because I know some of you are going to go back in the States. So you might want to call a full blood count a complete blood count, right? That's fine for now. Once we start thinking about training for the competition, then we'll start to try to correct that language. But if you want to say, I want cardiac enzymes versus I want troponin, or rather, can we get cardiac enzymes or can we get troponin? Either one is fine with me for now, right? Okay. Neurological. What are we thinking? Stroke assessment. Great. How do? Face. Okay. Feet. Arms. Could be eyes. So what you guys are digging for is FAST, face, arm, speech, time, right? Okay, also known as the Cincinnati Stroke Scale in select circles. All right. What do we think we want to know in neurological, based on what I've taught you this year? What are some things that we can think about? Perla. Pupils equal round reactive to light and accommodating. Very nice. That's great. That can tell us a fuck ton of information, right? Absolute butt ton of information just from the pupils alone. What else? So focal deficits, which are going to be our things like our arm drift, maybe our slurred speech, our droopy face, maybe a specific area, paresthesias or loss of motor function. I like that. GCS, very good. GCS is what? Very good. And it was developed to do what? Specifically in the context of? Yep. And used primarily in patients that are, this is where GCS falls short. GCS was developed to trend patients that are comatose in intensive care. That's why it was originally developed. And we all latched onto it because it's a fun little number thing, right? It is super duper useful, and I want you guys to know how to calculate a GCS. Everyone is always asking you for GCS. However, GCS is a trending tool, right? Patients with a GCS of 3 will walk out of the hospital just fine sometimes. Patients with a GCS of 15 will die. You'll hear very often GCS less than 8 intubate. That is not a hard and fast rule. It's a guideline. There are some patients with a GCS less than 8 that we won't intubate. There are other patients with a GCS more than 8 that we will, right? So, and it's certainly not a drop everything, stop everything that we're doing and intubate this patient because their GCS is less than 8, right? It's a, okay, their GCS is less than 8, maybe we should consider securing an airway somewhere down the line, right? So, we talked about FAST or Cincinnati. That's kind of our like really basic stroke assessment. It's actually fairly sensitive. I think it picks up like 93% of large vessel occlusions or something like that. That's not bad, right? It's not great, but it's not bad. What's a more definitive and longer stroke assessment? Anybody know what we use? NIH stroke scale? NHSS?
I thought that was for prognosis.
So it can be used for prognosis, but it's often used for trending in immediate as well, right? So yes, it's another one of those things that was originally developed to sort of figure out, but it is definitely something that you'll see used if you're on a stroke team in a hospital. You'll be recording serial NIHSS stroke scales in order to sort of trend how that patient's progressing.
Like at a 17 or something like that.
It's crazy. Yeah, I wouldn't be able to walk you through it off the top of my head. There's cards for this, right? PMS, what's that mean?
Power motor sensation.
Close, pulse motor sensation, very close. So pulse motor sensation, this is a down and dirty part of our trauma assessment. When we get to fingers and toes, we always check, do we have pulses in the extremities? Do we have motor function in the extremities? Do we have sensation? And it's not, we have 5 out of 5 flexion and 3 out of 5 extension. It's, they squeeze my hands, they have motor function, done, right? Same thing with sensation. What finger am I touching? Index finger, good, we're fine, right? Reflexes can be useful in certain situations. Cranial nerve exam. Anybody?
Yeah, that's great.
Well, cranial nerve exam? We're pro cranial nerve exams? Everybody know all the cranial nerves off the top of their head?
Can you smell coffee?
Good to go? Can you smell? No? Everybody's looking freaked out? Cranial nerve exam? All right, we'll teach you how to do that at some point. Don't worry about it right now. It's okay. All right? Something to consider, though, and can be very, very useful, especially in cases where we're thinking about head injuries, we're thinking about strokes, we're thinking about other stuff, right? We limb tone and powers up there. A glucose is 100% incredibly important. I have seen many a patient come in with a pre-hospital crew that says, this patient is having a stroke. And you go, boop, nope, this patient has a glucose of 1. Right? So glucose, anytime you have a patient that has neurologic deficit, whether it is focal or not, get a glucose. Question? Good?
We were saying normal glucose is around 5?
Yeah. All right. So yeah, you have low glucose. I've seen patients with focal neurologic deficits. Facial droop, arm drift, Glucose in the States is between 80 to 120, so glucose at 20, give them some D50, or really D10 now. All of a sudden you cured their stroke. You're God. Congratulations. We got urine electrolytes up there. Love to see it. This is great for cardiac as well. Urine dipstick can be super useful. We can also do tox in the urine, right? We only get a few drugs, but it's something that can be useful. Head CT. And I swear to fuck, if any of you call for an EEG, I will start throwing shit at you. All right? We're not doing EEGs. That ended up there because some group last year was like, what about an EEG? And I was like, oh, I don't want to make you feel dumb, but I'm not a huge fan. Right? Okay. So far we've talked about some bloods that I want really in any critical patient we need to get. So we need an FBC, we need a venous gas, we need urine and electrolytes. There's one more that we always care about that hasn't popped up yet, but it will. Does anybody know what it is off the top of their head? Say again? So C-reactive protein, so a marker of inflammation, not the one I'm thinking of, but very often not a bad idea. Liver function. So LFTs, we call it in the States, are complete metabolic panels, sometimes you'll hear, right? So there's a bit of crossover with what's on a UNE versus what's on an LFTs, depending on where you are. Sometimes electrolytes are in one, other, or both. But that's the other one that we want to think about. So we're looking at a critical patient in SimWars. One of the things that you'll see our trained teams do when they get to that part where they're starting the IVs is they'll say, let's start IVs and let's draw a venous gas, full blood count, CMP, and urine and electrolytes. Then they may add cardiac markers if they're concerned for any sort of cardiac problem. They may add blood cultures if they're suspicious for an infection. They may add CRP if we're thinking of any inflammatory process. They may add any number of things, but we almost always start with those 4 baseline bloods at least. Okay? Great. I don't have anything written down here. What do you think we do for musculoskeletal? Could you elaborate, please?
I wish I could elaborate. Look, feel.
Inspect palpate auscultate percuss. Great. You know, listen to those muscles with your stethoscope. Get that nice muscle sound. You're right, though. Inspect palpate for sure, right? So if we have a musculoskeletal problem, oftentimes this is trauma. Often, not always, but oftentimes this is trauma. So what do we care about? Decap-PTLS, baby! That's what we're doing. So we're palpating that extremity or the entire body. If it's a multi-system trauma, we're palpating. We're feeling for that swelling. We're feeling for that tenderness. We want to feel bones and see if they're grinding against each other or bending in ways that they shouldn't be doing that, right? What else do we care about? Care about things like tone and power? Absolutely. So if we're concerned for a more local musculoskeletal injury, we can start assessing tone and power. We can start assessing range of motion, right? How far we can move extremities around. We also care always, always, always about distal function. So do we have distal perfusion and do we have distal neurological function? So if I have an injury in my upper arm, I want to make sure that I can still feel my hand, that I can still move my fingers, that I still have a pulse down here, right? There's your musculoskeletal stuff in a nutshell. Sure, yeah, there's a whole bunch more stuff, but that's the stuff that we care about right just now, okay? What about integumentary, skin? Look at the goddamn skin, right? So we're looking for things like burns. We're looking for things like color. What skin-related emergencies can you have? Stevens-Johnson. I knew you were going to say that. Stevens-Johnson syndrome. You can. In a case of Stevens-Johnson syndrome, Carl, what would you see?
Sloughing.
Yeah, you'd see sloughing of the skin, right? So we look at the skin, right? There's not very many skin emergencies outside of trauma scenarios, but the skin can be a great indicator of other emergencies. If I told you looked at the skin and you saw a diffuse urticarial, so a diffuse hive rash, what would you be worried about? Anaphylaxis. Is that just an integumentary problem? Definitionally, it's not, right? So where are you looking next? Airway. Perfect. See? So we can get that information. If I told you the skin was blue, what are we worried about? So we're thinking of hypothermia, we're thinking hypoxemia, right? What are we going to do? Airway breathing, right? Check a temperature. Figure that shit out, right? If I told you the skin was bright cherry red, what are you worried about? Now we're thinking. Carbon monoxide poisoning. What are we going to do? Get them out of the carbon monoxide. Yeah, carbon monoxide. Get them away from the carbon monoxide, right? So carbon monoxide poisoning. Get them on high flow oxygen, right? So the skin can be an indicator, can be a little window into what's actually going on with the patient. Very rarely is there going to just be a skin emergency, but emergencies can show through the skin. So we care about color, temperature, condition. We care about inspecting for decap BTLS, or deformities, contusions, abrasions, penetrations, punctures, burns, tenderness, lacerations, and swelling, right? And we use that stuff to see what's going on. If I told you the patient was diffusely burned, all of a sudden now we have an integumentary emergency, right? We've burned the patient's skin away. We talked a little bit about burns a couple weeks ago. Anybody remember any pearls? Burn pearls? Say again? Rule of nines, I think I heard. Nice. So Parkland formula, right? So rule of nines is our way of estimating surface area. Parkland formula is our way of calculating the amount of fluid that we need to give to a patient that's been burned. What kills you when you've been burned? Dehydration. Hypothermia. Infection. Right? That's the skin. Right there. The bane of any emergency provider's existence. What is in our psychosocial secondary survey? Inspect, palpate, auscultate, percuss. Very good. What are we thinking here? So, suicidality is a big one, right? How do we assess that? Ask. Very good. You ask. Turns out asking people if they want to commit suicide doesn't make them commit suicide. Crazy. What else? Yep. So harm to self, harm to others. Come on, guys. There's other stuff out there you can ask. We're kind of living in the psychological area right now.
Ask them how their day's been going.
Yeah. Ask them how their day's been going. Great. What else? So things like sleep deprivation, things like activities of daily living, things like do you hear things that aren't there, see things that aren't there? What else?
Eating.
Are we eating? That's a great one. That's a great question to ask a paramedic. How much food is in the patient's fridge? We get to see the inside of their house. You don't. That's a social assessment. What's the state of the house? Right? Are they homeless? Are they housed? Or are they unhoused? Are they housed? Do they have people at home looking after them? Do they have a pet? Do they have friends? Was anybody worried about them? Was anybody calling after them? These are things that you can ask paramedics that you won't otherwise get the answers to in the hospital, right? So that social assessment piece can be very, very important. It doesn't tend to come up very often during SimWars, but it's an important skill to have when you're out there in the world, right? We like sexy trauma and bad medical calls, but these are the calls that are actually the hardest to deal with, right? And I say that to people all the time. The cardiac arrest is the easiest call you can do. You just do the algorithm, right? Trying to find a place to send this person that maybe doesn't have food in their house and has nobody checking up after them and their porch is falling in, right? That's the stuff that's actually hard. All the algorithm stuff is easy, okay? So these are important things for us to know. So we talk about things like a mental state exam. Has anyone heard of a mental state exam? Those of you that are in SC1 about to do a psych rotation, you're sure as hell going to learn about it. Right? So we care about things like the patient's appearance and their behavior. Right? We care about things like their speech. Is it fast? Is it slow? Their affect and their mood. Do they seem happy? Do they seem sad? Right? We care about their thought processes and their thought content. Are they thinking their own thoughts, or do they think that someone else is putting thoughts into their head for them? We care about things like hallucinations, visual and auditory, as well as other types of hallucinations. We care about all that stuff. And these can be the most difficult calls that you'll deal with, and these are the calls that you don't get a whole lot of practice doing during SimWars, because they don't tend to come up in the competition. But they are also emergencies. Move on to some other more easy stuff. What about gastrointestinal? Here we go. Everybody know how to do an abdominal palpation? Light, deep. How many quadrants? 9. Crazy. Right? 4 quadrants is fine for me. Left upper, left lower, right? Divide at the umbilicus, right there. That's okay. 9 is awesome. Light and deep is good. At or below the patient's level is great. Looking at the patient's face to see if they grimace while you do it, all well and good. Is that all going to happen during a trauma assessment? Probably not. We're going rapid. We're feeling that just straight to deep palpation. Do we have heat in the abdomen? Do we have distension? Moving through it very, very quickly, right? But in a more slow scenario, maybe we'll do all that. Percuss the abdomen. What do you think about that? You want to percuss for hepatomegaly in 10 minutes, the first 10 minutes of an emergency? Nah, probably not, right? Do you want to maybe percuss to listen for any sort of edema or like fluid wave or ascites? Maybe so, right? So it's about triaging out the stuff that you may or may not want to do. Full blood count, liver function tests, venous blood gas, UNE. DRE? Thoughts? If there's concern for GI bleed, right? Maybe fecal occult blood, right? We can test to see if there's any blood that's not visible in the stool. If we're concerned for a GI bleed, that might be indicated, right? E-fast, indicated in abdominal pain patients, yes or no?
Depends on the type, why.
Depends on why. Why would you think about doing an E-fast, Carl? Trauma, sure, what else?
Yeah, like maybe if you had like an acute abdomen or suspicious for like an ulcer or something like that.
Okay, so ulcer could be,
Like drinking history, for instance?
maybe, don't tend to get free fluid in the abdomen in the places that we look at in an E-fast. That tends to be more acidic abdomen, like ascites, but not a bad idea. What about things like ruptured organs? Like what? So yeah, you could have a splenic rupture, normally associated with trauma, but sometimes spontaneous. What else?
Obstructions?
Okay, not going to show up super well on E-fast, but maybe. Say again? Internal bleeding from what? Ooh, baby! Little AAA. If you got a ruptured AAA, and you see that shit on E-fast, who do you call? The morgue, homie. That person's dead as hell. If you rupture a AAA and you're not anywhere but on an operating table, you are toaster roasted. But you can look at the abdominal aorta with an ultrasound. It's not typically part of our E-fast, but it's definitely a skill that you can do, right? And you can absolutely see that aortic distension. You can see that aneurysm. Now, if you see that aneurysm and it's ruptured, you're fucked. But hey, what else can we see on an E-fast? We can see free fluid in the abdomen from ruptures. I'll tell you right now, if there's a ruptured ectopic pregnancy, you're going to see free fluid, right? If there's a ruptured appendix, you're probably going to see free fluid, okay? So things that we're looking at an acute abdomen, an E-fast might be the place to go, at least to start. Now we're thinking CT, we're thinking surgery for these people, but I can give you a little bit more information in the meanwhile. What about an abdominal x-ray? Useful, not useful? When?
If the patient hasn't pooped and
Yeah, so we're super constipated. Ingestion of? So anything that's radio-opaque. So if you eat something that can be seen on an x-ray, absolutely an abdominal x-ray is the way to go. That's super common in children, where you look for the battery, or the toy car, or whatever else, and you find it, or the coin, right? What else? What can abdominal x-ray tell us? Really big one. Air where? Under the diaphragm, good man. All right, air under the diaphragm, which tells us something's broken somewhere. Air's not supposed to be in there. Got in there. How'd it get in there? Came in through a hole. Good stuff. And then CT abdomen's the big one, right? That's what you'll see more often than not. You'll see CT abdomen. What's up?
Would you be more likely to see free air under the diaphragm in a chest x-ray?
You could also see free air under the diaphragm in a chest x-ray. Absolutely. 100%. Definitely. Fecal occult blood. So DRE, take in, take out the poop, put the poop on the thing turns blue if there's blood. Good stuff. You're very welcome. Everybody good? All right, one more. Oops, skipped it. Genital urinary. What are you thinking?
Again, it depends on the,
Yep.
on the chief complaint.
Depends on the chief complaint. Very good. Very good. A lot of similar stuff with abdomen, right? A lot of overlap with abdomen. So yeah, we could do ultrasound. So maybe in this case, maybe we're considering an EFAST or some other type of ultrasound, like a pelvic ultrasound or a transvaginal ultrasound, right? That's if we're concerned for maybe like an unruptured ectopic or an ovarian cyst that's causing some sort of abdominal pain, right? Absolutely. So ultrasound's a great tool in the abdomen, and specifically in the lower abdomen. What else? Inspect palpate auscultate percuss. No one is going to do pelvics in SimWars, but in the real world, that may be indicated, right? When we talk about trauma, when we do our trauma assessment, especially if you're doing an ATLS-style trauma assessment, we absolutely are inspecting the genitals for any bleeding, right? We're inspecting the perineum, looking in those areas, and we're also checking the tone of the anal sphincter in ATLS, right? So these are things to consider as well. What else in genital urinary? What kind of tests, maybe? Urine for bacteria. Yeah, so we can do urine dip for bacteria. We can do urine microscopy to look for any bacteria. That's great stuff. So this is a great one when you have that 75-year-old person presenting to the emergency department with acute altered mental status, don't know how long it's been going on, coming from a nursing home. You hear that story, that person has a UTI until proven otherwise, right? There's your urine right there. Get a real quick answer on that one. What else? Beta HCG, 100%. Anybody of childbearing age that comes into the emergency department? What else? Blood would show up in a urine dipstick, absolutely. You'd see blood in the urine if it was there, you would see it. Think about STD panels, right? Again, probably not going to be a chlamydia case on your SimWars, but this is real world emergency medicine now. People come into the ER all the time saying, my junk hurts. Figure it out. Good stuff. What are some emergencies that can be genital urinary true emergencies? What are we thinking? So we think foreign objects stuck in some place? Absolutely. There's where our x-rays and our ultrasounds can be useful. Think about ruptured ectopic, ruptured ovarian cyst. Torsion, good man. So testicular or ovarian torsion, right? So what do we do to figure out if those are going on? Ultrasound, Doppler ultrasound, right? We want to see if there's blood flow in those spaces. And 9 times out of 10, that's a clinical presentation, right? Sudden onset pain, especially in a guy, sudden onset pain, absent cremasteric reflex, right? Thinking torsion. Normally they're vomiting all over the place because it sucks, right? But that's a great classic genital urinary emergency that if we catch early and intervene on, it's going to be perfect. Right? Anything else? Okay, renal stone, absolutely. So people with kidney stones come into the emergency department all the time. Not normally something that's going to kill you, but it sure hurts like hell. So what are we thinking about for those folks? Fluids, absolutely. We're thinking CT because we want to see where exactly that stone is in the ureter, right? Okay, so PPH or worse, they're having a baby, right? Won't normally come up on SimWars because we've kind of made this rule that we're not doing OB and we're not doing pediatrics. But I don't know, if we're feeling frisky, maybe we'll throw you in with the obstetrics mannequin, right? So that's an emergency. That's a real big emergency. Delivering the baby, right? Postpartum hemorrhage is another really, really, I wouldn't say incredibly common one to see in an emergency department, but it does happen, especially with the rise of home birthing. So you might see PPH. So what about those patients? What are you thinking of for them? Or APH, yeah, absolutely. Take me 30,000 feet. Don't talk about frontal rub and uterine massage. What do we do with a patient that's hypovolemic? Volume resuscitate, stop the bleed, right? Same thing. A little bit different methods, but same thing, right? So things to consider, right? Lots of genital urinary emergencies out there. Trauma is the one you hear about a lot, but it's not the one that's most common, right? More often than not, it's this torsion It's this ectopic. It's this, tried to have my baby at home and now I'm bleeding everywhere. It's that type of stuff. And that type of stuff will kill you pretty quick, right? Good stuff. And last but not least, just to think about a little bit, secondary survey in trauma. So we talked about our rapid trauma assessment. We're going to show you a rapid trauma assessment on video tomorrow. However, once we're done with that rapid trauma assessment, that doesn't mean that we're done assessing that patient. So the rapid trauma assessment is our first 60 seconds after we do our ABCs to try to see what are our life-threatening injuries. Once we get through that, we're going to wrap back to the top again, and we're going to go through in a much more methodical fashion, right? We're going to go through, we did our pupils, but now we're going to look in the conjunctiva. We're going to look in the ears with the otoscope. We're going to look in the nose. We're going to really look in the mouth. We're going to feel all the way around the neck instead of just the C-spine, right? We're going to do all that stuff. So that's our secondary survey in trauma, and we'll show you what one of those looks like also on video, also hopefully tomorrow. But I want you guys to be cognizant of the fact that once we're finished with that head to toe, that doesn't mean we just write off the patient. Because the other thing that can happen is those assessment findings can change, right? You can turn around 5 minutes later and all of a sudden now you got a distended abdomen that's full of blood and you didn't have it before. So we got to keep up with these secondary surveys. And that's a repeat of our initial physical assessment with slightly more detail, okay? All right. That's what we've got for tonight. I know it's pretty loosey-goosey, but I want you guys to have that information as we go forward into the internal competition. And this is us starting to lay the foundation for the building blocks that we're going to put on top during phase 2, right? When we start to talk about pathology, we start to talk about disease presentations to the emergency department. I need you guys to have these basic skills for working this stuff up so that we can start to inspect each individual issue, right? Questions about anything at all. This is the last chance you're going to get to ask questions in the lecture setting before the internal competition. So I'm talking everything, anything, including logistics. Hit it.
So with the stuff taught today, is that, like, how do I contextualize it in terms of an actual sim?
Yeah.
It seems like there's a lot of assessment stuff, but stuff that could possibly be done by other.
Yeah, absolutely. So I would say contextualize that in the sim in the way that it needs to be. And I know that's kind of a milquetoast answer. But at the end of the day, you are deciding how the scenario gets to be run. So if your team leader says, hey, grab a cardiovascular assessment, says that to the assessment person, that's fine. Maybe also says that to the cardiac person, to the circulation person, right? You guys are deciding how the scenario is run. The thing about it is we want to kind of be on this, at least somewhat the same page when it comes to what these assessments are going to entail. Cool?
Actually, one more.
Yeah, please.
So if assessment is doing something and like they, for instance, want help with like the auscultate the chest or like note something with the chest, and can they just like tell airway and breathing? Is that like kind of?
So if you're getting answers about what's going on with the patient, you can. Asking, yeah. So you could. It really depends on the situation.
Okay.
Maybe airway breathing's busy digging in the airway trying to get an eye gel, right?
Okay.
But yeah, absolutely.
Okay.
Yeah.
As long as we gotta let.
Yeah. And if the answer to the first question in your assessment is we just assessed the airway, it is this, that's also okay.
Okay.
Right.
Okay. Thank you.
Questions?
When you guys we get a lot of like that type of questions, and I just want to clarify, like, the roles are there to make it easier for you. They're not something you need to stick to down. Like we advise you to stick your roles because we've seen that works best. But there's no like definitive list of things that each person in this role does. It's a team sport. You're working as a team. So if you are a team member who needs help, put your head up, look around, see who in your team can help you, okay? The only hard and fast rule that I want to put out there is team leader doesn't get involved in doing something, okay? And that's just because it's the best way to run a scenario, and you need someone that can oversee everything. But don't be like, oh, I want to do this, but I don't think that's part of my role, or I want to ask someone, but it's not part of their role to help me.
All right, I'm going to repeat that for the people online so I don't forget everything you just said. So one of the things that Adara just mentioned was the fact that the rules are guidelines. They're there to help you and help your organization in this scenario. They are not hard and fast rules aside from the team leader never touches anything and other stuff like the person doing compressions is very important, like things like that, right? There's not this, we've had a few instances of people being like, getting asked to do something and then snapping back with, that's not my job. If you have free hands, it's okay for you to help out in someone else's role. We just don't want to see one person running the entire scenario, taking over for everybody else without permission. But we're okay with a team leader designating someone to do something that isn't necessarily exactly in that list of stuff that's their job, right? Okay. Other questions? Go ahead.
For example, if I'm airway and I see a problem with circulation, do I say that problem to the circulation person or to the leader first?
So knowledge sharing. If you're airway and you see a problem with circulation, share with the whole team, which means sharing it with the team leader, right? That is if it is actually a problem. We've got a lot of instances, they're becoming less and less of people breaking in with shit that's not important, right? The blood pressure dropped from 108 to 106. Whoop-de-fucking-do, right? But if you're looking at there and you're like, oh shit, the SAT just dropped to 70, or oh shit, that patient's in asystole, or like in VFib, and you're the first person to notice it, be like, hey guys, patient's in VFib, right? What else? All right. Over where? Oh, all the way in the corner over there. Hiding.
The main difference that you see between rapid trauma assessment, DCAP, BTLS, and then this secondary surgery?
So rapid trauma assessment, DCAP, BTLS is by definition rapid, and that means that I want it done in less than 60 seconds from start to finish. Okay? Secondary survey doesn't have to be that short.
So you do your ABCs, and you do your rapid trauma, and then if the patient is like, if there's no change, you go on to
In trauma. Patient comes in with trauma. ABCs, D, disability, and E, exposure are parts of our rapid trauma assessment. And then once we're done, we're happy with where we are, we've stabilized all the life threats, we can go back up to the top and start again with airway, work our way back down, and do a more detailed assessment the second time through. That's it?
So this was all kind of like after the initial
Yes.
stable, guys
Yes.
stable, and now we can just like go
Yeah.
further.
Absolutely.
So if the person, okay.
However, if you go to B and you're doing a breathing assessment, pull some of the stuff from the rest of the exam that's going to help you figure out what's going on.
Okay.
Especially if you think there's a problem with breathing or if there's a problem with circulation.
Yeah.
Don't wait to get down to B to be like, okay, now I'm going to do a cardiovascular assessment, right?
Okay.
And they do overlap, but these are a little more exhaustive
Okay.
than your initial. Sorry, I stopped talking to them.
I'm going to repeat that for the folks online. So it's okay to pull some stuff from these secondary surveys up to our ABCs, right? Like our auscultating for lung sounds, and especially our bloods when we talk about getting that large bore IV, right? That type of stuff, it's okay to pull it up. You should pull it up.